Next up, I invite Dr. Fumiko Chino from the Memorial Sloan Kettering Cancer Center to be talking about financial toxicity. We've talked about palliative care, some examples of programs of how to support patients. Now we get to hear about financial toxicity. Dr. Chino is a cancer researcher, an assistant attending in radiation oncology, and a co-lead of the Affordability Working Group at the Memorial Sloan Kettering Cancer Center. She's also a director at the Cost of Care Group, an NGO focused on affordability in healthcare, and the recipient of the inaugural 2022 ASCO Excellence in Equity Award. Her research really focuses on the financial toxicity of cancer care, survivorship, healthcare disparities, equity, and access. And we're really excited to hear you today. Thank you for being here.
Thank you so much for this kind invitation to speak. I'm really passionate about the topic of financial toxicity. I'm hoping to give you a little bit of a whirlwind tour of it over the next 20 minutes. I have no relevant financial disclosures. When we think about financial toxicity, I always show this ASCO opinion survey because I feel like it is so striking that when we talk about the financial burden of a cancer diagnosis, there's actually slightly more people who are worried about the financial impact of that diagnosis than from dying of cancer. This is a problem for our patients, it's a problem for our patients' families, and they're having to make some pretty significant sacrifices in order to afford their care. This is something that's percolated all the way up to our banner medical journal, the New England Journal of Medicine, with this concept that costs are a side effect of treatment, just like any other side effect. And although we would never start someone on a chemotherapy regimen without warning them of the risk that they may lose their hair, or they may have painful peripheral neuropathy, we're routinely committing our patients to potentially financially toxic regimens without really giving them significant warning about that. This is something that's translated over to the lay media as well, which is that patients just get it. They understand that care is unaffordable because it's been unaffordable for themselves, for their family members, for their coworkers, for their loved ones, for their neighbors. We understand this is a problem. And when we say, well, I have no financial disclosures about financial toxicity, I have to be truly honest, which is that I do have a financial toxicity disclosure in that it's taken a lot from me, and I personally have skin in the game for financial toxicity research. It's important to me because it's taken so much from me. In 2017, I shared my own personal story about how after my husband was diagnosed with cancer, we had excruciating costs related to his treatment, and that after he died from cancer, those costs followed me for over a decade. And this is what we're talking about with financial toxicity. We're talking about real people. We're talking about real burdens, and we're talking about it affecting their families. When we say financial toxicity, my mentor at Duke, Dr. Yusuf Safar, said, this is really a new name for a growing problem, and he said this in his seminal manuscript in 2013. I want to point out there that 2013 was less than 10 years ago. This concept is new. This idea that we needed to even popularize a term to describe what was happening to our patients, it's stunning. We're talking about something that's only growing over time. What is financial toxicity? When we really think about the term, it is often misused to mean that there are growing healthcare system costs. Or we talk about, oh, how insurance was charged $20,000. When we talk about financial toxicity specifically, it's actually a patient-facing problem. It's the problems that a patient has related to the cost of their care. And the NCI says that, you know what, people with cancer are more likely to have this problem. What I said in my own commentary was that, you know what, even with health insurance, the high costs of care are really leaving some vulnerable American families adrift in debt. That's me. And that these costs can have real quality of life effects, real effects on quality of care. When I level set for financial toxicity, I show Dr. Yabrov's work from the American Cancer Society to talk about how much of a problem this is for patients. We're talking about the patient economic burden being both out-of-pocket costs and also time costs, which is I couldn't work because I was on cancer treatment. I couldn't work because I needed to go for my scan. My partner couldn't work because he or she was taking care of me. And we're talking about over $20 billion every single year. And what I like about this study is that it shows that these costs are really durable over time. So even 10 years after a cancer diagnosis, you can have both out-of-pocket costs and also time costs. We know that financial toxicity matters for our patients. We can see it reflected in decreased quality of life. We can see it reflected in decreased satisfaction with care. And ultimately, we can see that it actually is eroding the quality of care that patients receive. There are a lot of studies that show that there's an erosion in quality of life related to high costs. I like the diagram on the left because it's messy, and quite frankly, cancer's messy. Advanced disease sits in the middle, and there's an interrelatedness between advanced disease, quality of life, financial toxicity, and quality of care. They're all interrelated. It's actually very hard to pull out what's driving what. But I will say that costs can be a factor. And we know that people with high costs are just much less likely to rate their quality of life as good. They're more likely to have problems with physical, social, higher anxiety levels, higher fatigue. We know that there's an erosion in satisfaction with care, so people without financial burdens, with low financial burdens, have a kind of standard bell curve distribution for their satisfaction scores, whereas people with high financial burdens, it's all shifted towards the less satisfied. And the specific things that get eroded in terms of this validated questionnaire for satisfaction were general satisfaction, financial aspects, satisfaction, that totally makes sense. But these questions about the technical quality of care that go down when burdens go up are really important to highlight because they're trust questions. And part of the financial burden quality of care dynamic is that we can erode people's trusts with their diagnosis or their treatment when their costs are too high. We know that there's an erosion in the quality of care based on affordability, and we have about a quarter patients who are medically non-adherent related to costs based on our study. I will say that there's quite a variation of research that shows how much non-adherence there is, but they pretty much always find some. Our study found that about 1 in 5 didn't even fill a prescription related to the costs of the medication. And I think more terrifyingly, 1 in 20 that skipped, took less of, or didn't even fill their chemotherapy prescription. So something that could immediately compromise the efficacy of their anti-cancer treatment. We know that if financial toxicity is decreasing something's quality of life satisfaction, it's raising things, personal and family burden. We know it's increasing your risk of bankruptcy, and ultimately it's increasing your risk of mortality. We know that many studies show that there's increasing burdens with a cancer treatment. We know that our study found at least 2/3 of patients were having to make at least one sacrifice. That includes, I see that the numbers there didn't translate, that's fun. Over half of patients who had to use their savings and about a quarter of patients who had to borrow money or go into debt in order to afford their cancer treatment. We know that this burden increases over time, as we previously discussed. If you're on active cancer treatment, your burdens will only increase. And this study was published by Dr. Shankaran late last year, specifically talking about, 3-month surveys at the end of 1 year, they had basically 3/4 of their patients had some sort of major financial hardship related to the cost of their care. This was for patients with metastatic colorectal cancer. We know that there's actually objective harm, so cancer can ruin your credit. We know that there are patients who are having to go into foreclosure. We know that people are having debt collector calls from their cancer treatment. We know it can harm you both now and also later if you are so lucky to survive your cancer diagnosis. We know that there's an increased risk of bankruptcy. So this is the seminal work of Dr. Ramsey out of the Seattle group, specifically looking at how cancer was an independent risk factor for bankruptcy. You were more than 2.5 times more likely to have to declare bankruptcy in the context of a cancer diagnosis. And ultimately that matters because if you have the ultimate negative financial hardship related to a cancer diagnosis, you can have the ultimate negative everything outcome, which is death. And so in a follow-up study, Dr. Ramsey showed that there was an increased risk of death if you had bankruptcy related to a cancer diagnosis. We know that if there's an intersectionality between quality of life and financial burden and advanced disease, that there's also an intersectionality between healthcare disparities and the social determinants of health and structural racism. And it's really hard to say what's driving what in terms of who has increased financial burden, but we know it exists. We know that there are, every stop along the care cascade from a normal health outcome to cancer diagnosis and follow-up, there are blocks where you can have language barriers, you can have community barriers, you can have health literacy barriers, and you can have barriers within bias from within the healthcare system. We know that there's worse financial impact for people of color. So this study was of Black women with breast cancer, showing that they were more likely to have an adverse financial impact of their cancer. They are more likely to have financial barriers to care. They are more likely to have transportation barriers to care. And they were more likely to lose their health insurance after a cancer diagnosis. In a study of all comers, this was a national study showing that Black patients were actually 5 times more likely to lose their health insurance after a cancer diagnosis, and more than twice as likely to say that they were hurt financially from that diagnosis. We know that there's an increased risk of homelessness. Our cancer treatments are so financially toxic for our patients that 1 in 20 Black or Latinx women are actually becoming housing unstable related to the cost of their care. In the United States, with all of our resources, our treatments are causing homelessness for some of our patients. And this is patients with early stage breast cancer, something that you would expect to have a good long-term prognosis. And so you may survive, again, your breast cancer diagnosis, but then left financially devastated. We know that this is actually driving some of the unequal access to clinical trials, and that the patient populations that are the ones we honestly want within our clinical trials to have a diverse sample to make sure that the treatments that we offer you are actually going to benefit you. We know that the burden of these hidden costs of clinical trial participation are a real obstacle to overcome for some of our patients, and quite frankly, they're the reasons why they can't enroll. We know that whatever cracks were in the sidewalk before the COVID-19 pandemic, they are certainly more exposed now in terms of healthcare inequities, and vulnerable populations, whatever disparities they were facing before, they're certainly worse now. In our study of AYA patients, those are patients who are diagnosed and treated before the age of 40, so a vulnerable population at risk for financial toxicity. We found that 2/3 of them had some sort of major economic event related to the pandemic, including about 1 in 5 who lost their job or were furloughed, didn't have enough to pay their rent or their medical expenses. So we know that this will unfortunately pay off for probably another decade in terms of worse reoccurrences, worse mental health outcome, worse survivorship care. I just spent 15 minutes talking about how bad things can be, but I want to spend the rest of my time talking about what we can do to try to fix them on an individual level, on a cancer center level. I really do want to focus a little bit on the care continuum and talk about how, these factors that contribute to financial toxicity for cancer survivorship, for people with metastatic cancer, how we can think about, there are many different ways we can intervene because there's so many different ways that this factors in. We know that we have an ongoing need for treatment and or surveillance. We know that there is a real problem in the United States with inadequate health insurance, and people are actually locked into their job because they don't want to lose their health insurance that has in-network their cancer providers. We know that our treatments are very disruptive to work, and that we may be forcing people into an early retirement or locking them into a career path that allows them to be able to still function in whatever way with their peripheral neuropathy. We know that these chronic side effects, cause disability. We know that that potentially could require a caregiver. I was out of the workforce for over a decade when I quit to take care of my husband with cancer. And we know that some people have limited assets to begin with, and we're certainly depleting their savings related to a cancer diagnosis and ongoing need for treatment. When we think about kind of the public health model for financial toxicity, how do we prevent financial toxicity from forming? What's the vaccine for financial toxicity for our patients? What's the secondary prevention? How do we reduce the impact by diagnosing it early? So what's the rapid test for financial toxicity for our patients? And then how do we prevent financial toxicity, from causing chronic effects? How do we at least soften the impact of ongoing disease, like financial toxicity? So what's the Paxlovid for financial toxicity? I do think that education is really important for both providers and patients, really thinking about how this problem is an issue and we should normalize conversations about it from every perspective. There's a real role for patient navigators for our patients to make sure that they're getting the resources that they qualify for already, that they're hooked up to every single program that could potentially assist them, and then being proactive, not reactive to their needs. For example, if I prescribe a medication, it shouldn't be at the time when the person is at the pharmacy telling me that there's a $7,000 copay, that before we start doing the paperwork to help them. Improving access to health care really can make a difference, because a lot of people require that income coming in, and also that's where they get their health insurance. And it could be not only their health insurance, but also the health insurance for their entire family that's contingent on them working. On the provider level, how do we encourage high-value care, decrease low-value care, like cost-aware prescribing patterns? How do we streamline our clinics and enable telehealth to be delivered equitably? And how do we advocate on our own cancer center level for real practical solutions for things that cost money? Financial counseling can really help patients. This randomized trial of meeting upfront with a financial counselor actually improved the understanding of costs for the vast majority of people who participated. And so I think it's some evidence that just meeting with someone to actually know what you're in for can make a difference. We know that we need to improve within medical education our own ability to plan how do I actually educate the next generation so that we're not so cost blind. There are modules that you can take for free that are available from Dell Medical School that you can work through yourself online. But I think this is a real concern, because we're blithely sending new trainees out without any capacity for having these discussions with our patients. We know that our own surveys show that the vast majority of trainees actually have met someone who couldn't afford their care, because everyone has, but that they feel that their own education is actually marginal or insufficient for the vast majority of times. We know that there are really simple, practical solutions, things that we can advocate for ourselves, for our patients. Just the idea that, my follow-up clinic slot is 20 minutes long, and yet I know between driving and waiting and rooming and vitals, it could take 4 hours of someone's day. You moving more efficiently, trying to figure out what the optimal, flow for clinic is can really make a difference for our patients. And parking is stupid. I'll just leave it at that. The fact that we're charging patients for parking is ridiculous, and we know it can be an incredible expense for our patients. And the idea that parking is a barrier is something that gets my goat every single day. We know that telemedicine can lower costs for our patients. Again, this is sort of a no-brainer, but if we can deliver it equitably, we know that telemedicine can really improve affordability, can decrease your travel expenses, can decrease your time off of work. Our survey found that 2/3 of our patients said as such. And we know that, we can use technology, we can use app-based financial navigation to try to help people connect with a resource that they qualify for already. And so this trial from Dr. Yusuf Zafar's team actually showed that he could triple the rate of patients who are both applying for and receiving financial assistance. So again, the idea that you could be getting help that you don't even know is there is so frustrating. It's like a missed connection, but like way less sexy. This idea that maybe we can use technology tools to really help facilitate that connection. How do we diagnose financial toxicity to make sure that we're catching people? By screening. There is a yes/no screen that we can ask for financial toxicity. It's just a checkbox. You can use the NCCN problem list as long as someone actually looks at it, which is always my concern when people will check off all these things and then it falls into a hole. There is a validated screener for financial toxicity, which is an 11 question with a 12th challenge question. It's scored on a Likert scale. It takes 5 minutes for your patients to complete while waiting in their clinic. It asks both subjective and objective questions about harm in terms of, for example, worry and also, being able to afford cancer treatment. I think it is, in terms of the most commonly used validated tool for financial toxicity, this is definitely it. It's available for free. We should never forget the fact that when we are talking about financial toxicity, we need to talk about all the things that they had pre-existing in their lives before they had cancer diagnosis. So screening for things like the social determinants of health is important. So in blue, number 2 is the question that we added to our universal screening, which is specifically, do you have not enough money to pay for food, housing, clothing, medicine, repairs to your home, or transportation? Because we're routinely missing some of the gaps that patients had even before, if you're living at the poverty line now and then you have a cancer diagnosis, you're just right into that hole, essentially, and then we just have to dig people out. How do we soften the impact of financial toxicity before it has really lasting effects on our patients? And this is just cost conversations, I'll be honest, is the simplest thing I can tell you. It's like, we had talked earlier about how if you just have an earlier conversation about palliative care, it can make a difference. They probably don't need it then. And the same thing with cost conversations. If every single person had a conversation that said, hey, cancer care can be expensive. If you ever have a time where you can't afford your care, I would like to know about it because there could be solutions, there could be help. And what we know is that the majority of patients do desire some sort of cost conversation, and yet sadly, the real minority of patients have it with either their doctor or anywhere within healthcare system. That's a social worker, the person taking their copay, the nurse assessing their other needs. We're not having the conversations that I think are really necessary. And the reason why cost conversations can help is that they can help. They don't help every single person, and they don't lower your costs to zero. And I think we always need to moderate our expectations in terms of what we can do within our clinics. But our studies show that if you have a conversation about costs, that it can help reduce those costs. And the main reason actually it helps reduce costs is that it actually just gets people into the financial assistance that they qualified for already. So again, that missed connection. Sometimes it requires physicians to appeal to insurance. Sometimes it requires someone switching from Zofran to Compazine. We're talking about most of these things that don't actually involve any kind of compromise of cancer treatment, which is the #1 issue that patients were worried about when they said, hey, this is the reason why I don't talk about costs with my patients or with my provider. When we think about from primary to tertiary prevention for financial toxicity, when we think about education, diagnosing early, normalizing cost conversations, it's really trying to think about many different ways that we can improve our optimal care for our patients and prevent less long-lasting harm from the financial burdens of treatment. These are all much more patient-facing interventions. I have a whole nother talk on policy interventions, so you can ask me back next year for that. When we think about mitigating financial toxicity, I think it's really possible in the United States, but it's growing, and this is, a problem because cancer outcomes at risk. And we have this, idea where we spend a lot of money at the bottom of the triangle in the United States, and we really need to flip the triangle and spend a lot more money on prevention. That's true for everything. That's breast cancer screening, that's healthy nutrition, that's anti-smoking campaigns, and yes, it's also in financial toxicity mitigation. I'll leave everything with this slide where it's from my cartoon in the LA Times where we specifically talk about, at least my story, this idea that there's this false dichotomy in the United States between your money or your life, it's bankruptcy or death. But sadly, what I know from my own history is that you can lose both. I lost my husband and I was left with financial burdens. I was both financially and emotionally devastated. And it's just something that shouldn't happen in the United States today. I think we have so many resources. We have so much goodwill. We have so much intelligence. We need to really create solutions. So I really appreciate your time. Thank you so much.
Thank you for that really inspiring talk and for sharing your own personal story. It's, I think, really impactful to hear about it, something that as a medical provider myself, I'm oftentimes struck with, how as a medical oncologist or our nurses or our advanced practice providers, how do we educate them? And I think about that with different copays, different deductibles, and most patients don't understand the basic parts of their coverage. And yet then we're asking providers to also do that in a limited time visit. And I'm wondering your thoughts about it, because I know you've spent a lot of time thinking about this.
Yeah, so most providers don't understand health insurance either, so we're all in the dark about this. It's an incredibly complex thing. I think some improving health literacy and health insurance literacy can definitely help, and there's some evidence to show that that can actually improve financial toxicity outcomes. But I do feel like, this is a comprehensive thing where it's like, I think the burden is on all of us to try to fix this issue, so that includes rallying all resources from the nurse to the provider to the social worker to the financial care counselor and having people work together as a team. Actually, Levine Cancer Institute actually published on a financial toxicity tumor board that they put together, which was actually trying to gather everyone within the healthcare system that had skin in the game to improve outcomes for patients and try to think about solutions on a system-wide level. So you're not wrong to say it seems insurmountable, but I think if the first step is always just to try. Right? That's how we got any new cancer treatment, is someone having an idea and pursuing it doggedly. So.
Then I have a second. Oh, we have a question at the microphone here. Thanks.
Hello. Hi, Dr. Chino. I really, really enjoyed your presentation. My name is Shantae Drake Ford. I've been living with metastatic breast cancer for 7 years, and I'm an advocate. And I've been to many talks and educational forums about financial toxicity. But one thing I think I've seen what's missing is the actual insurance agencies. We have so much representation, even at this conference in itself, with researchers and pharmaceutical agencies and things of that nature, but we never have them or any agency as a direct person to speak to kind of get that information. Of course, we have third parties that can help us. Have you pursued any partnerships with insurance agencies? What have they responded? Is it like a big no-no? I'm just kind of curious.
No, I think that's a really good question, which is essentially, if you actually bring all stakeholders to the table, you can actually get more things done. So I think that's a really salient point to make. For the type of research that I do, I'm very much, I don't want funding from insurance companies, so I get it. That's one barrier for me personally. That's my ego. But no, I think that there is some work to be done in terms of, one of the rising burdens on patients has been the burden of prior authorization, which is something that sits almost exclusively within the insurance company's hands. So we're starting to do a little bit more work on the burden of prior authorization, specifically from the patient perspective, and how the role of insurance kind of plays into that. So I think there's a lot of additional work to be done. And like I said at the beginning of the talk, this is a new field. We're still trying to gather, who are the key players and how do we get them invested in this? Because for the insurance companies, I think they're very tired of being painted as the villain in this fight. And I do think that there's a way that we can wrap them in and be like, hey, you can be the hero because you're the person that facilitates this person getting treatment that can preserve their life. And that's nothing to scoff at. So I like that. I've not specifically reached out to insurance companies, but I think I'm gonna take a page from you.
Going on that, I would say that you might be put on hold for about an hour. I'm Patty Kellerhouse. I'm a MBC survivor. And I think I didn't hear you mention anything about Medicare. But I was shocked when I became Medicare eligible, going from my insurance that I had with my company. My out-of-pocket cost for these drugs was astronomical. And I was like, oh, I'm paying $10 a month for my CDK4/6 inhibitor. Now, in January, it cost me like $3,400. And then it takes, I have to get reimbursed once I become catastrophic. So I did advocate for the out-of-pocket cap that I was working with the American Cancer Society very hard. So.
No,
There's definitely some financial toxicities that really do put a lot of stress on patients. And thank you. I really enjoyed this talk.
Thank you. I really appreciate your advocacy through the ACS because the passage of the Inflation Reduction Act and trying to close the gap for patients with Medicare, I think is going to make a huge benefit for our patients. Again, that was the 40 slides that I exited from this talk to make it down to 20 minutes.
I got you.
Again, I'll see you next year. But no, I think that there's, again, when we think about insurance design, when we think about health policy reform, there is so much slack in the line that we can pull in, and we can make care more efficient and more affordable, and that's the dream, right?
Can I add one more thing? About 4 years ago, I remember the people coordinating my appointments at the center where I go were complaining because all of a sudden I couldn't get my Faslodex shots the same day as I saw my oncologist. I mean, do they even think about the patient with that kind of rule? And was that a federal rule? Do you know what that was?
I apologize. I do know that when that reimbursement changed, or when the billable codes couldn't be stacked, and I do not know the intricacies of that, but I do know it affected a lot of patients. And if you think about that extra visit, we're talking about additional parking costs, or additional day off of work. We're talking about how that really impedes care, and for really no reason.
Right.
There is not a reason.
Thank you.
I know I have lots more comments as questions as well, but we're going to have to move on. So thank you, Dr. Chino. And people will be available after this session for additional questions or comments or conversation.